Hello, Dr. Tony. It's almost 3 o'clock, and we'll give our other potential viewers an opportunity to log on. But this also gives us an opportunity to really check all the things that are necessary for this presentation. As I said, this is absolutely my first Instagram Live presentation. And I'm going to try and fill it full of all the information that I think you need to be safe. As again, we're going to be talking about gender-affirming treatments, really for the entire month of June, which is Pride Month. And because of the COVID-19 crisis, we really can't get together in person. And in Seattle, that's a real big issue because that's a big event for our community here in Seattle. I am a huge ally of the LGBTQ community, and in this day and age with, let's say, everything that's going on politically, the viral pandemic, everything, we really should be standing together. So my purpose in really being here is to try and help you navigate a lot of the complexities. The particular talk today is on female to male affirming treatments. And FTM treatments is my specialty, I guess I could say right now, because it's in such high demand. Next week, we will be talking about MTF, male to female, and I'll actually have one of my colleagues and former fellow who does genital reconstruction for male to female patients and can really augment our knowledge there. But more than that, to give you an idea of what is necessary to make that journey for those of you interested in that. And then after that, I will have my colleagues that are experts in hormone replacement and what they can give us in terms of knowledge as to how to best navigate those waters. And then we're going to leave the final week in the month of June for the basically a wrap-up. Any questions that you have, feel free to DM me, email me, and my email address and website are below. And we will make sure that we answer all of your questions. So without further ado, I'm going to give you, for those of you who don't know me, I'm going to give you a little bit of information about me. I'm currently the president of the World Academy of Cosmetic Surgery, and within that group, we actually have a group of surgeons that are very interested in gender-affirming surgeries. So unfortunately, we didn't get a chance to do that this year because of the COVID-19 crisis, and our London meeting was canceled, and it looks like it'll be canceled for an entire year. But we had a roundup of about 6 surgeons willing to actually share their surgical treatments, and then several medical doctors willing to share their medical expertise on gender-affirming treatments. But today, it's about FTM. I'm a graduate of the University of Washington, right here in Seattle. Go Dogs. For those of you who are here in Seattle, I'm really proud to say I am a proud Washingtonian, going from medical school all the way through from grade school all the way through medical school right here in the state of Washington. So I didn't know anything else existed until I got shipped out to Kentucky to do my surgical residency. I am currently president and medical director of La Bellevue. That's my current practice. If you need to reach me, you have my address below and phone number. I am a board-certified cosmetic surgeon, and I've been practicing for 33 years, exclusively this specialty. And I've dedicated my practice to really helping all patients, especially the LGBTQ community, reach their full potential in whatever way that I can help them. At the end of the day, there are certain things that we can do by ourselves. We can exercise. We can be healthy. We can lose weight. We can gain weight. We can do all kinds of things by ourselves. There are certain things that we can't do by ourselves. In this particular case, we have several of our patients that are female to male transition, and there's no way that they can remove their feminine breast features without someone like me. And one of the things that I want to do is to help you navigate the waters as to how you really evaluate what you're going to do and how you can do this. So again, June of this year is Pride Month, and this is an agenda of what we'll be doing. And again, keep track of this, and this will be recorded and shared later. But if you've got a specific interest, email me, DM me, do whatever you need to do. Just get me the questions. Every Wednesday this month, we'll be answering all those questions. So I look forward to hearing from you. Okay, knowledge is safety. For the entire community, knowledge is safety, regardless of whether it's medicine, or if it's politics, or if it's just policy. The fact is, the more we know, the better we understand each other, and the better we understand each other, how do you say, the more tolerance and the better our lives will be. In this particular case, what you do before and after your procedures really has a huge impact on how well you do. And so knowing your goals, like what do you really want out of this? For some of my patients, they don't want nipples. They want a perfectly smooth chest. You need to communicate that. For some of my patients, they want a very masculine chest, as masculine as they can make it. And that'll also require leaving some tissue to actually augment the pectoralis. So we'll get to that, to the details, but more important is knowing the procedure. And then finally, knowing the treatment plan. What are you gonna do? Define that. Don't just say, hey, you're the doctor, you know what's going on. I don't necessarily know what you want, and it's important for you to communicate that. And then finally, the risks. Go into it with your eyes wide open. All right. I want to acknowledge the gender continuum. The fact is, surgery tends to be binary. It's either male or female, and there's not a lot of non-binary results that I can actually show you because, it's, how do you say, you don't get a little bit wet if you go swimming. You jump in the pool. In this particular case, we will be talking in binary terms from a surgical point of view, but I want to confirm and just reassure the entire spectrum of gender, including our non-binary patient or potential clients, that I acknowledge, and this is a talk that really addresses your concerns as well. The aesthetics of gender recognition is really important. Boy, nobody understands what that is because no one, I would say, the general public has never analyzed it. We're going to go over a little bit of that with respect to chest reconstruction. And we'll do more of that later for the male to female discussion. So I'm going to introduce some new concepts in female to male body sculpting. And I introduced these at the WPATH conference in Amsterdam 2016. And all my fellows have learned this. In fact, I've trained 16 fellows to date, and about 5 of them are actively doing chest reconstruction around the United States, and I even have one in Australia. So this is wonderful that we can actually share this knowledge. So for you, what's required to prepare for surgery, after surgical care and potential complications, and then again, every Wednesday for the entire month of June, we'll be answering all questions. All right, by the nature of this particular talk, it's surgical, there will be some nude photography, but because of the modesty rules of Instagram, we'll be masking out some things. In addition, I'm going to show you an actual video of a chest reconstruction from start to finish, which is a film clip from a film called Finding Kim. And it's a story of a trans male patient making the transition. And I'm just lucky enough to have been Kim's doctor. So, all right. First of all, there's no right way, there's your way. And every way is different. This is a continuum. And I recognize the continuum is about you, not about me and not about your neighbor. It's about you. Surgery isn't always necessary. Let's acknowledge that. Sometimes hormones are enough. If the hormones are enough to allow you to pass and be your gender identity, you don't necessarily need surgery. So But living successfully in your identity is perhaps the most important thing that we can help you do. All right, pre-op considerations. Understand your procedure, your operation. How many patients come in and say, just do this operation, and then they have no idea? Oh, you mean I'm going to have scars? Oh, where are those scars going to be? And what are my real, expectations? Well, understand what you're going to have. And then understand your doctor. I mean, sometimes your doctor has one way of doing things, and maybe that way isn't for you. I'm hoping that's not the case, but you just never know. And your doctor should really understand you. This is a relationship between you and your doctor. And it's not just your surgeon, but your PCP, your mental health provider, anybody that is going to help you with this transition, it's important to have a personal relationship with. Obviously, informed consent, risks, complications, you need to know. And then finally, achieving your goal requires really explicit communication. Know what you want, because if you don't know what you want, you might not know what you're going to get. And let's face it, the best way to hit a target is to aim directly at it. You can't do a 3-bank shot on a cue ball, on a billiard shot and expect you to hit it 100% of the time. So, pre-op considerations, this is not rocket science. Optimal health. Be as healthy as you can, because if you're not healthy, well, you're not going to do as well. Getting your proper mammogram, your colonoscopy if you're over 50. Big thing, no smoking. Smoking is bad for your health. In case you haven't figured that out by now, it really does harm you, because it decreases the oxygen the rest of your body can get, because it occupies the hemoglobin in your blood with carbon monoxide. So you can decrease the oxygen delivered, even though it looks red, your body's not getting the oxygen. Obesity, obviously, it's not healthy to be obese. And all the medical literature that we have today says that people that are obese have greater complications. And we won't get into that other than to say it's always better to be healthy. And then the support systems. Your family, your friends, your doctor, your counselor. Everybody should be on board, because this is your team. If you need help, you need to have them. And that's perhaps the most important thing about being safe. All right. When to stop hormones? Big question. For the female to male, some people say yes, some people no. Say no in terms of stopping testosterone. I say, well, skip one dose, because I really would rather not have a huge spike in hormones. Just skip one dose. And then 3 days after the surgery, you can go ahead and continue. And it's been very useful for in my practice. Few complications, and most patients don't even feel the change. For my male to female patients, the estrogens, we can talk more about that later, but it does make you bleed. And I make my patients stop at least 2 weeks in advance. And if you don't, unfortunately, bleeding after surgery is a problem. And you just don't want those problems. Aspirin, another big problem. ASA is basically a medical term for aspirin. Aspirin can make you bleed. One aspirin will poison the platelets in your blood, meaning it'll decrease their effectiveness for 6 weeks. Fortunately, your body creates a lot of platelets. So, those platelets that were ineffective are now replaced with platelets that are. But 10 days is more than enough time. Theoretically it says 5, but I always say 10, because I just never believe that it's enough. And more is better here. Blood clots to the leg. We call that deep venous thrombosis, and those are the things that can actually kill you. DVT, or pulmonary embolism, can kill you. So what do we do for those? Compression stockings. The granny stockings that we can't stand. They're uncomfortable. You hate wearing them. Well, it's good for your health, believe it or not. Get up, walk. Don't be sitting around. Have your helper and your assistant get you up. And then finally, if you've got a prior history of blood clots, then you're going to need anticoagulation. But we're not going to get into that more, but just understand that may be necessary. And then finally, prepare for your time off. This is not a weekend operation. You aren't going to be able to get up and go back and start driving truck or a bus or cleaning floors. Okay? All right. This is, as I said before, this is a partnership. It's you, it's your doctor. You have to be a team. And if you're not, things don't go nearly as well. So be fully invested. And your pre and post-op instructions are absolutely critical to the outcome. If you don't follow them, the chances of complications go up. Classic example, you take aspirin. You can bleed during the surgery. Or you're a heavy smoker and you don't want to quit. You can actually kill tissue. Your chances of infection go up. This is a partnership, and we want what's best for you. So this proper preparation is maybe the most critical thing that I can say to you before any operation, but certainly for our operation. So I encourage you to just do your part. Okay, medications. So these are the common medications that cause bleeding. I'll actually have a list of them all in a minute, but you know, we already talked about hormones. Estrogens, stop. Testosterone, plus minus. All right, and then the prescription medications that you're taking, I think they just need to be evaluated by anesthesia and by your surgeons. If they make you bleed, you're going to have to stop taking them and replace them with something else, or just be able to just stop taking them. Anesthesia may have you stop or only take medications at a half dose. Whatever medications you're on need to be evaluated, so list them all. Now, this is the list of all the medications that you are not allowed to take before surgery. So I expect you to memorize this because there will be a test at the end. If you don't get it right, or if you miss one of them, nah, just joking. The fact of the matter is, you really only have to know a couple of things. Number one, you can take Tylenol. If you can't take Tylenol, well, then you can't take anything else for pain prior to your surgery. Anything else needs to be approved by your physician. All right. Preparing for anesthesia, I already talked to you about stopping smoking, and I repeat that because it's so important. Smoking causes all kinds of problems, and I don't want to get into the problems, just understand it's not good for you. With respect to food, stop eating at least 6 hours prior to surgery. Now, there are some variations in the theme. My anesthetists allow my patients to drink clear water up to 3 hours before the surgery. Consult with your physician and your team as to what's best. Know your allergies. If you don't divulge them and you get a drug that you're allergic to, you can cause all kinds of problems. And then, again, the current medications that you need the night before. Oftentimes, high blood pressure medicines are modified. Asthma, if you take an inhaler, bring it. Because if you don't and you have a problem during surgery, it can really affect your outcome in a way that you just don't want. Cholesterol, plus minus, that's probably not going to kill you during surgery. So, and I have an array of anesthesia providers. The fact is, both nurse anesthetists and MD anesthesiologists there in the United States are excellent, and they provide excellent care. Now, big question, how much does this cost? I put this out to everybody because everybody keeps on asking me, how much does it cost? Well, it's a big range in the United States, but you can see some of them are very high, like, facial feminization. And, in some parts of the world, that can be up to $100,000. Then there's genital reconstruction for male to female and female to male. The fact is that it's a huge range. Maybe top surgery is one of the more affordable. What's surprising to me is that electrolysis is $60 an hour. And for those of you that are counting, there's some patients that have clocked 600 hours. That's $36,000 for electrolysis alone. So understand you're going to have to plan for this. Fortunately, in the United States, a lot of this is now covered by insurance because Center for Medicare and Medicaid have deemed this medically necessary. So now let's get into what I think is new ground. It's the artistic concepts. Now, Aaron Spelling, he's a producer, of TV and movies and the like, but he basically says about beauty, you can't define it, but you know it when it walks in the room, meaning you can see it. All right. The Greek mathematicians tried to define beauty, but I don't really want to get in the middle of that because I don't think they got that right. The person that got this right was Leonardo. He's my hero. And why? Because he's an observer of the human condition, human anatomy especially. And he develop the proportions of the entire human body, which in my particular case is really important because how we create our surgical results are really a function of the proportions. And Leonardo got his clue from a guy named Vitruvius about 1,500 years before him. So this is right out of Leonardo's book, his notes, and you can see he's looking at the proportions of the face. The proportions of the face are, the lower is 1/3 here, 1/3 to there, 1/3 to there, and then if you divide the lower third, you got 2/3 on from the chin to the lip and a 1/3 from the lip to the nose. The bottom line is this is all over the entire body, and he did this for the entire body. This is how we got to our idea of perfect proportions. And if you take a look at Leonardo's drawings, like this is Ginevra, it's in his perfect thirds and perfect fifths. All right, masculine versus feminine is what we're talking about today. It's a whole body image. It's not just one thing. It's not just Adam's apple. It's not just breast. It's not just hairline. It's the whole package. So it's what we see. Now, for the female versus male body shapes, which is probably what we'll talk about, you know, the male is more straight and the female is more curvy. The male shape of the face is more square and the female is more of a triangle. And, you know, if we take a look at just the bodies, just to get an idea, the female body is much more curvy and more slender and more petite. The male body, you can see right now, I mean, just flash back and forth between the two. You know, there's a huge difference in just plain old shadow. So we have to learn those things. With respect to, I guess, the male versus feminine, again, it's the whole body image. So what is chest reconstruction? It's masculinizing the chest. All right? We have to make it proportional to the rest of the body, but it is focusing on the chest. And the chest really is focusing on the pectoralis major muscle. So we want to remove the feminine portions and we want to keep or sculpt the masculine portions. That doesn't sound too complex, but philosophically it is, because what's masculine, what's feminine? Well, with respect to gender identity, again, we're talking about a binary result here, even though we acknowledge the gender nonconforming or gender non-binary portion of our part of our community. So with respect to gender fluidity, meaning patients that sometimes identify as male, sometimes as female, sometimes as non-binary, and it may change. In general, I wouldn't recommend doing any surgery because you just don't know where you stand. So, and some of my colleagues have a different point of view on that, and some patients do as well. It just requires a conversation. All right, what are required for chest reconstruction? Liposuction. Most of my colleagues don't do liposuction. We liposuction everybody because that's how we get our best sculpting. We'll get into that detail in a minute. Double incision mastectomy is the most common procedure because virtually everybody has got a lot of skin. The nipples are too large, the nipples are too low, and the breasts are too low. And then the potential for what we call a keyhole, where we make a little incision around the areola to get the breast tissue out and leave a masculine chest, is possible, but that's in probably less than 5% of my patients because you have to meet the criteria. And we'll get to that in a minute. So study the human form, the critical proportions. Every person is different, and we have to create a chest that's proportional to that person, not just one way of doing it. It's not a cookie cutter. And the bodybuilders give us a real excellent clue for what we're trying to do. Now, everybody knows Arnold. He's from Austria, but he was also governor of California. But if you take a look at him in his prime, take a look at that pectoralis muscle. That's the center of his chest from the mid-clavicle down, and that's the edge of the pectoralis. You notice the intersection of those two is right where the nipple goes. Pretty fascinating, but that's the way it is in virtually all the bodybuilders. Here's another bodybuilder. That's the mid-chest line, that's the pectoralis major, and that's where the nipple goes. This is how I center the nipples. It's not always perfect, but it's a lot more consistent than just saying it's so many centimeters from here to here, and then we swing a line like some surgeons advocate. Again, I presented this at WPATH, which is the World Professional Association of Transgender Healthcare. It's one of the largest of in fact, it is the largest organization of its type in the world. I presented this in 2016. But it is not a breast reduction, we know that. It's a creation of a masculine chest. So the tissue above the nipple is masculine. The tissue below the nipple is feminine. So remove the feminine, keep the masculine. And I'll get you some graphics on that in a second. All right. The feminine portion, again, has to be removed. The liposuction that I believe needs to happen with all chest reconstruction is used to sculpt the chest. Loose skin, obviously you're going to take that out. And then examination of your patient's anatomy is critical. All right. This is a patient we're actually going to show you at surgery, but you can see here that that is roughly where the nipple will go. You can see where the pectoralis would be, and here's the pectoralis line. So anything below that, feminine. We're going to get rid of it. You can see it graphically now. Anything above this, you don't take everything out, you sculpt it. And you sculpt to enhance the pectoralis. All right, here's a fat pad right dead center in the middle, which is a feminine fat pad. You want to get rid of that. And you've got one here, and then you got one hidden back behind here as well. Okay, laterally, you can see that's where the new nipple is going to go. Below it's feminine, get rid of it. Above it, masculine, sculpt it. Not particularly difficult to understand, but now this gives us at least a framework to work by. So here's a patient. And you can see here, what we're planning to do. All right. Now, I'm going to show you his surgery. It's a time lapse, lasts about 35 seconds. And I'm going to give you a little bit more information about this. So if you're squeamish, why don't you just close your eyes until, you can keep listening, but close your eyes until I come back, okay? And here we go. Let me get out of the way. This is the time-lapse sequence. This is from a film called Finding Kim. And Kim was one of my patients. And, it is a full-length feature film that was first presented at the Seattle International Film Festival in 2016. It benefits the trans community, and you can see the process by which we produce this. And you can see right now that right here is the pectoralis major shadow. And that's the beauty, is we actually want to create that shadow. I have absolutely no financial interest. I think it's a wonderful film, not just because I actually starred in it and got an IMDb listing for it, which is kind of exciting. But, Kim, I know you're probably watching. Thank you for sharing your experience, because it's not just your experience, it's everybody else that was in that film that really advocates for the community. And this is Kim like 3 weeks after his surgery. So it's a pretty significant difference. I mean, for those of you that have Kim's, let's say, challenges, there's no way that you could go from here to here without a trained surgeon to do this. And that's the key. But if you, again, imagine from here down, feminine is gone. From there up, masculine. Follow the pectoralis, fat pad goes away, sculpt that. So that fat pad you can see has been removed. That's really important. Understand that, so when you're talking to your surgeon and you're looking at your own body, now some of you don't have as much meat on your bones, and you might not need as much of this, but if you have to be sculpted, make sure that you are getting the right amount of sculpting in the right places. And these are just some results. And this is a really good example of one of my Afro-American patients. And you can see not all Afro-American patients will scar poorly. This person scarred pretty doggone well. And I would have to say that's probably 80–85% of them. So our Asians, like I'm an Asian, I'm sorry, I don't scar really well. Every scar I've ever got on my body has been like a big, thick scar, and then it finally will resolve. All right, those are the rough guidelines And I hope that you understand them, because if you deviate from those guidelines, if your surgeon does, if you're planning and doesn't really meet these guidelines, I find there are problems. I'm going to show you some examples of this. Okay, this is a patient. He actually brought this photo with him 6 weeks after his chest reconstruction surgery that he had somewhere else. And, it was like, it's flat, but I'm not particularly happy with the results. And then he finally pulled his shirt off, and this is what I see. So I'm going to give you a minute to kind of study this, but you tell me, because you can see it doesn't look right. Okay, the breasts are gone, the nipples are there, but it just doesn't look right. So let's kind of look at this from an analytical point of view. All right, first of all, this doesn't follow the pectoralis muscle. Sometimes you can't, but in this particular case, he could have, but it doesn't follow that, so it doesn't really fit. It's almost a straight line. In the human body, there are no straight lines. Leonardo even told us that. So then the nipple, too high, because here's the pectoralis major. It really belongs right there. And then this fat pad is still there, and that fat pad is still there. And then you got probably a little bit too much stuff here as well. So if I were to plan this, that's the mid-chest line, that's the edge of the pectoralis, that's where the nipple actually belongs. So this is something that's not really published anywhere, but this is something that I've used for well over a decade, and it works extremely well, and it's reproducible. So this is our plan. Mid-chest line, pectoralis. This is the incision. This is where we want the incision to go. This is the fat we want to get rid of. And this is 3 weeks after the surgery. The skin graft that we took from here to move the nipple there, I moved that skin to there, took the nipple tissue and moved it to here, the areolar tissue. So we basically just traded places. Boom, boom. Okay, and that's a composite of what happened. And this is like about a month later. And you can see that even a month later, much improved. Why? Critical proportions of the human body were reconstructed. That's the important thing. Da Vinci had it right. I wish it was my idea, but it's not. All I'm doing is observing what Da Vinci said. And then, here, again, this is the skin graft from here, and that is the nipple tissue from there. Not all of it was there to begin with, but tattoos can fix the majority of that. All right, other mistakes. Skin. Nipples are too low. Here's the pectoralis is up here. This is let's say an ethnic thing that this Native American was doing for himself. But so that had nothing to do with surgery. But he came in and basically says, I'm transmasculine, but that doesn't look right. Obviously, it was an attempt at a giant size breast reduction instead of a chest masculinization or a chest reconstruction. And I wish we could have gotten this incision a little bit higher, but those are the limitations that we had. All right, this is right off the internet. Okay, all I did was surfed around, and you can see nipples too low. Not exactly enough skin was removed. All the feminine portions of this are still there. All right, here the symmetry is just not there. The incisions are almost straight, in the wrong position. Fat here. Again, it really should mirror the pectoralis major muscle. All right, and then I'll just give you a couple of more examples. This is the one I really wanted to show you because this patient was actually happy, at least on the post that I saw, but it's pretty flat. There's almost no masculine chest there because they didn't leave anything. It's flat, and dog ears. In general, dog ears are things that if you see it at the time of surgery, you ought to take it. And the only reason you shouldn't take it is when you run out of room. Like, let's say we're making our way towards the back, and you'd have to, you can't operate on the back of the patient when they're laying on their back. So keep an eye, just understand there are some limitations, but for the most part, we can take care of the majority of what we see at the time. All right, how did we learn the aesthetics? Well, we certainly didn't learn them in medical school. Frankly, I didn't even learn them after my training. And I did an 18-month cosmetic surgery fellowship with probably the founder of the American Academy of Cosmetic Surgery, Dr. Richard Webster. The fact is, we didn't have this training. Artistic training is a missing link. And I'm going to give kudos to a good friend and colleague, Dr. Peter Schmid. And he actually was one of the founders of Sculpting for Surgeons, where we took 10 surgeons together and they brought us together and taught us how to be sculptors. And this was my first sculpture. I'm sorry, it's almost embarrassing, but I've gotten a lot better since that time. And this is one of the instructor's sculptures. It's getting better, but it's a study of human figure. And we didn't study the male figure because it was much more difficult. The female figure, at least in this class, for us beginners. And each one of these guys over here are leaders in cosmetic and plastic surgery around the world. They're my friends, they're my colleagues, and we spent a whole week learning how to sculpt in clay. And I can tell you, it is an eye-opening experience. You should, look at that. So aesthetic results, if it doesn't look right, speak up. Look at before and after photos. If they don't look quite right, you don't even have to understand the analytics behind it, but understand that, hey, that's not what you want. So, and then, if you see it at the time, and I encourage my patients, if we're marking and they're saying, well, I don't really like that, or I want this, or, that's a real problem that, we can't overcome unless you communicate it. All right, scarring. It usually gets better. There are certain early treatments that we can use. Most of them are just creams and steroids. Swelling, it always happens, but it gets better after 3 days. Cold always helps, and then drains are really important. Okay, for the people of color, I'm one of them, so I understand. So our group has a particular issue with scarring. There's just no way we can get around it. We have an increased incidence of widened scars, big thick scars, hypertrophic scars, and even keloid scars. Keloids are abnormal growth of scars. In fact, if you have a real keloid, it's not just big and thick, but it keeps growing. And then dyschromia, which is a color irregularity, happens with almost everybody with color in their skin. And so, but not knowing these before surgeries for any procedure can be a real problem. So, all right, post-operative scarring. Most scars fade with time. Scars are often, the wide scars often need to be revised, meaning you cut them out again and sew it together, but this time under less tension. Does it guarantee a better result? No, but again, the surgeons will make the incisions and patients make the scars. So it's really an individual thing. Hypertrophic scars, there are a bunch of things that we can use to make it better, but they're not 100%. And then keloid scars are really special because they act like a cancer, but they don't spread. They just get bigger and bigger and bigger. They're difficult to control, and sometimes we even have to use radiation to get them under control. So this is an Afro-American patient with a big, we did a body lift. I just want to show you that they don't always get big scars. Look at this scar right here. I mean, that's a beautiful scar. So not everybody has a problem with it. Skin and color irregularities, fairly common. This is another patient of color, more Hispanic, and you can see that the nipples aren't exactly the same color. Okay, the melanocytes don't always survive, and they get better and better and better. But sometimes you end up with a pink nipple, and sometimes it's dark. All right, post-op, blood clot prevention. Get up and walk is your best thing that you can do, and support. Depression is not uncommon. Recognize it and call if you need help. And then the special concerns, there are no guidelines for mammography. There's some patients that say, well, if I have a chest reconstruction, do I need a mammogram? Well, even cisgendered males have breast cancer. So I think you should keep your antennas up, especially if you've got a family history of it. So surgery is a partnership. Doctor has a responsibility, you do too, and the two of you working together. Respect for each other. We need to respect each other's opinion. Very important. And then education is your critical key and need for safety. Again, Pride Month. This is our schedule for Pride Month. join me every Sunday and then every Wednesday for the answer to those questions. Any questions you have, text me, DM me. I'm around. And this is my beautiful city of Seattle. I'll have to say, you know, if you ever make it here, please stop by. We'd be glad to see you. But it's a beautiful city, and I want to thank you for all your time, your energy, and your dedication to the community.